need the mic on. Oh, there we go. Good morning, everyone. Welcome to Science Now. Science Now, until about 30 seconds ago, was almost Science Unplugged. We're having some it's ironic that technical issues. We have a great program, however. Remember, this is our venue for showcasing really cutting-edge research that's going on in our department right now. So today we have two assistant professors in the department who are really rising stars. We are going to focus on precision medicine, so the concept that by understanding the molecular pathogenesis of a disease, we can specifically target it and come up with safer and more effective therapies. So our first speaker, Lee Eckhardt, is going to talk about studies about ion channels and some of their interacting proteins and how that might inform approaches to inherited arrhythmias. And then she'll have about a half hour. And then our second speaker, Josh Lang, will talk about circulating tumor cells and what we're now sometimes calling liquid biopsies, looking at the molecular profiles of circulating tumor cells, not only to learn things about treatment response and prognosis, but also to sort of guide therapies. So, Lee, thanks for your patience.
Am I on? Hi. Am I on? Good. So I'm going to talk about precision medicine for inherited arrhythmias and start off with a story here. This is the resting ECG for a patient of mine who presented several years back, was walking with his cousin on Christmas Day, and they were having an argument. And then the argument got a little bit heated up, and then this particular individual fell to the ground, had a full cardiac arrest. Luckily, his cousin wasn't so angry with him that he didn't do CPR and call 911. And so he did call 911. They shocked him in the field. He was brought to the hospital, and then thus ensued a full workup as far as what happened with him. He made a full physical, neurologic recovery. And then the workup was really looking at structural heart disease, which was negative. His echo was normal. He had normal coronary angiogram for both anomalous coronaries as well as coronary disease. His resting ECG I've shown here is also completely normal. And his talk screen was also normal. So with that, I was asked to go and see him to see if we could figure out what caused this arrest. And talking to his mom, he said, oh, yeah, well, actually, he's been doing this for years because whenever he gets really upset about something, then he just falls to the ground and has a seizure. So he was seen by neurology. Neurology said, oh, you have partial complex seizures and neurocardiogenic syncope. Well, we all know that partial complex seizures usually don't result in a cardiac arrest. And so I suspected that there might be something else going on with him, and it might be stress-related because this happened during an argument. Next slide. So I put him on a treadmill, and on the treadmill, he's running along stage 4 of a Bruce protocol, and the tracing up on the upper left-hand side, you can see several beats of what are pretty narrow complex, but then there's Pvcs intermixed with those. And then on the right, you can see that he's then converted into full polymorphic ventricular tachycardia. You can advance the slide, please. And then this, once we pulled him off the treadmill, persisted into recovery. And so he has this clear stress-induced polymorphic ventricular tachycardia. So before I talk about him a little bit more, go ahead, next slide, please. I tell this story for a reason. My colleagues in the Inherited Arrhythmia Clinic and I, Craig January, Kathleen Maginot, Kate Orland, have talked about the importance of integration of clinical phenotyping with genetics and how that then helps us decide what is the best way of treating patients with inherited arrhythmias. And we've also introduced some science that we've done in the research lab that has helped understand some of these molecular mechanisms. But today I'm going to take that a step forward and a step beyond that with presenting 3 cases. And these 3 cases, I hope to highlight several points for you. One is that inherited arrhythmia syndromes are complex disorders, and sort of a one-size-fits-all usually does not work out. Second point is that you can use investigation in the research lab to help decide how it's going to be best to treat your patient. And then thirdly, a mechanism by which with new systems of developing model systems of iPS cardiomyocytes, we might be able to provide not just treatment options, but then create platforms for drug therapy. Next slide, please. So getting back to our patient, our slides are a little cut off at the top there. He has what Sylvia Priori described in 2001, which is called CPVT, or Catecholaminergic Polymorphic Ventricular Tachycardia. And this is exactly what it sounds like. It is arrhythmias, I think down the other way, bidirectional ventricular tachycardia, which you can see on the middle tracing there, starts off with a tachycardia that alternates its axis. So goes in two directions every other beat, bidirection. And then in that particular individual then degenerates to polymorphic VT. And this can happen both with the arrhythmias that these individuals have can either be bidirectional VT or polymorphic VT and can sometimes degenerate to VF. Their resting ECG has to lack other characteristics of inherited arrhythmia syndromes, must have structurally normal hearts on no medications, and then they might be classified as having CPVT. This is a highly lethal disease, and somewhere between 30 to 50% of individuals are dead by the age of 30 unless they're appropriately recognized and treated. Next slide. I've listed here several mechanisms for onset of Pvcs, including automaticity, and then two triggered mechanisms, EADs, or early after depolarizations, and DADs. In CPVT, we think that most likely this is related to a delayed after depolarization, or DAD, phenomena, and that is related to a calcium overloaded state, either from abnormal calcium handling, abnormal calcium reuptake, or because of leaky calcium from the sarcoplasmic reticulum. Next slide, please. And in fact, for CPVT, the two most common genes that have been associated with CPVT have been calcium handling genes. Listed on the bottom there, the first one is the ryanine receptor. And the RYR2 is the gene that encodes the ryanine receptor, and this is a gateway of calcium to leave the sarcoplasmic reticulum. And in a normal state, releases calcium to allow for excitation, contraction, coupling, and your heartbeat. But in this situation, in CPVT, the cycle is abnormally regulated, and then there's a calcium overloaded state, and you can have induction of DADs. Calciquestion is also another calcium handling protein that is present in the sarcoplasmic reticulum and helps with calcium homeostasis there. Next slide, please. The ryanine receptor is this ginormous gene, 5,000 amino acids. But for CPVT, probably most mutations fall into these four hotspots, colored in purple on the top of the slide, and then kind of listed linearly on the bottom there. Next slide, please. There are three other genes that have been associated with CPVT, but may be more related to what we call a phenocopy, meaning that the patients present like CPVT, but they may not actually have the same type of syndrome. These genes include KCNJ2, which encodes potassium rectifier channel KR2.1. The second one is ANK2, which encodes ankyrin B, which is a structural protein also associated with bidirectional VT. And the last one is TRDN, which encodes for triadin. And this is associated with the ryanine receptor and may be involved in calcium handling. So they're called phenocopies because the mechanism of arrhythmia might be a little bit different. Next slide, please. So we did genotyping on this particular patient, only testing specific genes to go with his clinical phenotype, which was CPVT. And by and large, he had not too much of a surprise. He had ryanine receptor mutation, arginine at position 420 to tryptophan, and this falls right in the middle of hot zone number 1 on the N-terminus there. Next slide. And then we initiated kind of classic CPVT treatment for him. Exercise restriction, trying to minimize stressful situations in his life, beta blocker treatment. He did get an ICD for secondary prevention. Next slide. Advance that. Thanks. And he did great. And so the last case, everything fits together. The genotype is one thing, and the clinical presentation, everything fits together in a nice little package, and then we go home, we feel pretty good. But that's where the easy part ends. Not every patient is going to follow those specific rules. This is a Holter tracing from a patient of mine who had, since her teenage years, onset of dizziness and near syncope every time she would exercise or get her heart rate up. And what you see here is maybe one sinus beat. There might be a sinus beat toward the end there fused with a very abnormal polymorphic ventricular tachycardia. So she went to a regular doctor. Next slide, please. And they did a Holter. They found that she had a lot of Pvcs, and so she was sent to an EP physician who then tried to do an ablation, and this failed, and she was referred to another EP physician who then said, I'll ablate the dominant PVC. And there were several ablation attempts done. If you advance the slide, there's a little animation that goes with this. On the heart, you can see that they ablated part of her LV apex, isolated papillary muscle. Keep going, Clint. Part of the RV. But this was, by and large, completely ineffective because in the EP lab, she was on isoproterenol. And if you just advance one more, that little red box is blown up there. You can see, especially on that lower trace there, that this is not monomorphic VT that we see in the EP lab. That's idiopathic. She clearly had something else. So luckily, after all of that, it was recognized that she had something different. Next slide, please. And so they sent off a broad panel for genotyping and came back with this result here, which was a mutation in KCNJ2. Advance, please. This is implicated in both CPVT and long QT syndrome. And so they looked at her and said, I'm sorry, we don't know what you have. So she packed her bags and she came to Wisconsin. When she showed up at our door, I was really thrilled because as a postdoc in John Mikulski's lab, in another clinical database setting, this mutation was actually sent to us, and I had engineered this as a postdoc in the Mikulski lab. So, next slide, please. KCNJ2 encodes the potassium inward rectifier channel. The little red swirly image is a single monomer of the channel, and then this associates with 4, so it makes a functional tetramer, potassium specific. Next slide, please. And KR 2.1 makes up, keep going. KR 2.1 makes up the this dominant component of IK1. IK1 helps maintain the resting membrane potential, but shown, and I'm not sure if you can see this super well, toward the end of the action potential, there's some blue lines that indicate terminal repolarization or phase 3 repolarization. So KR 2.1 is one of the potassium channels that wakes up at the end of the action potential and assists with repolarization. It's part of the repolarization reserve. Next slide, please. So if you isolate that DNA, next slide, and you study it in an EP rig in cells by voltage clamp technique, next slide, or next animation, there we go, then you can record a current that looks something like this. And then in physiologic voltages, you'll see the sort of N-shape, an outward current, and then at voltages minus about 78, then the current is inward, and so-called an inward rectifier for those reasons. For the purposes of what we normally see physiologically, the current is mostly outward and is part of your repolarization reserve. Next slide, please. So I gave this mutation over to Matt Kauscher, who was a postdoc in my lab and in John Mikulski's lab, and said, why don't you see what you can do with this and try and study this particular mutation under adrenergic stress. So what you see here are his traces of taking a wild type channel over here on the right side. If you advance the slide, I think I got an arrow. Yep, there we go. So the blow-ups there indicate really the response of the cell to adrenergic stimulation, which we induce by pKa cocktail. You have an augmentation of outward current, so increasing your repolarization reserve with pKa stimulation. But the mutant doesn't do this. It just sort of remains flat. Next slide, please. And then Matt went on and took this a step further to figure out, well, is this really a phosphorylation effect on the channel? Because in the beginning, I presented the issue with calcium handling here, and it's all initiated by beta-adrenergic stimulation, activation of pKa, and then pKa then goes on to phosphorylate a number of channels. So is this actually what's happening with our channel here? Advance. And in fact, that's actually what was shown. He mutated the phosphorylation site on KR 2.1 and then found that you no longer see this effect. So this is a phosphorylation effect, and you lose repolarization reserve. Next slide. And then this is most likely related to some sort of calcium sensitivity. We're just sort of beginning to try to understand this. But in the wild type situation, you might lose some of the outward current in a high calcium state, but with the mutant, the effect is much more dramatic. As you can see here with high calcium in the mutant on this part of the slide on the right, there's a greater decrease in the outward current. Next slide. So our future work really is trying to figure out, all right, well, how much of this is really a calcium handling story, or maybe it's an entirely different mechanism. Next slide. And so we've started some of this work with a transgenic mouse for this particular mutation, R67Q mouse, currently being worked on by a postdoc in my lab, Louise Riley. And this is some data that she and Ravi Vaidyanathan have developed. If you take we played around a little bit with stressing out a mouse to figure out how we can induce stress. So you can exercise a mouse, but it's hard to actually keep them going and get a nice, clean ECG recording. I've also played around with the concept of maybe we could put a cat in the room and see if we could really stress out the mouse. But it's hard to completely reproduce that exact scenario for each mouse. And so probably more scientific to anesthetize the mouse, record a baseline ECG, and then after that we'll inject epinephrine and caffeine. Caffeine unloads the sarcoplasmic reticulum from calcium. Go ahead and advance the slide. So if you do this to a wild-type mouse, this is a sort of their resting ECG as they're just lying there on the table sleeping. Next slide. And then when you inject epinephrine and caffeine, they get sinus tachycardia. And that's it. Next slide. When you do this then to the transgenic mouse with the R67Q mutation in a heterologous state, next slide, baseline looks pretty much the same. So resting ECG looks pretty similar. But then when you stress the mouse with epinephrine and caffeine, advance the slide, you get something that looks a lot like what I've already shown you, which is this bidirectional ventricular tachycardia. Next slide. So we have tailored this patient's treatment as CPVT because she clearly has a clinical phenotype, but also more importantly, the cellular phenotype is very much CPVT-like. She did okay on beta blocker and lifestyle restriction, but then we had to go ahead and add on flecainide onto her therapy because she, which is a class 2A indication for CPVT patients, because she still had some breakthrough arrhythmia. She's done fabulously on beta blocker and flecainide, and we're screening her kids. She's got one positive and one negative child right now. Next slide. Okay, so now for a totally rogue patient. This is a patient that presented with exercise-induced dysarrhythmia. If you advance the slide, I'm blowing up the part of the EKG I want you to focus on. Go ahead and advance the slide. There we go. If you look closely at AVL, you can see here that the axis of the ventricular tachycardia alternates. So this is really starting to sound familiar. Stress-induced bidirectional ventricular tachycardia. Should work out pretty much the same. This clinical phenotype looks like the CPVT patients I've already talked about. Advance the slide. So we treated him as such. We genotyped him for CPVT-associated genes, and he came up with 2 polymorphisms and the random receptor. So polymorphisms are shown in that on the lower right-hand side, those 2 red arrows are where his polymorphisms fall. So not in the hot spots that we've talked about. And polymorphisms also mean that it's shown up in wild type in control populations. So by and large, though, he did really well with beta blocker and as well as lifestyle modifications. Next slide. Until this past fall. This past fall, like a year ago, he presented with an arrhythmic storm. And his resting ECG still remained normal. His MRI still remained normal. His echo, everything else about him had still remained exactly the same. So he starts to present, he presents with this arrhythmic storm. So like the second patient that I presented, we added flecainide. Advance the slide, please. And this is what he did on flecainide. This flecainide in him was clearly pro-arrhythmic. This is him walking on a treadmill, just barely doing any exertion at all. and at a heart rate of 80 beats per minute. At rest, he's fine. As soon as I put him on a treadmill, 80 beats per minute, he goes into this very ugly polymorphic VT, which luckily self-terminated as soon as I just told him to lay down. Next slide. So we tried to take a fresh approach to him to see, is there something that we missed? Like maybe there's a sodium channel mutation that he missed all along, and this is why he has this sensitivity to flecainide. And what we ended up coming up with, however, was a variance of unknown significance in PKP2. Well, great, thanks a lot. Variance of unknown significance, what does that mean? Well, it's not disease-causing, it's not a polymorphism, so it's literally like we don't know, we just have to worry about it a little bit. Advance the slide. PKP2 has been associated with ARVC, and this guy totally doesn't have ARVC. His heart is structurally normal, resting ECG is normal, his family history is negative, but the PKP2 may be doing something different here, which we just don't quite understand. PKP2 encodes the plakophilin protein, and this is one of those desmosomal proteins that helps with cell adhesion. But then part of the desmosome then interacts with the rest of the cell and may have something to do with calcium homeostasis. Go ahead and advance the slide. And again. So I think to really get to the bottom of this, we need to take a really new and creative approach to trying to create a new model system with human iPS cells to help try to prevent arrhythmic sudden death, because standard treatment just didn't work out for him. And we still need to figure out what how we're going to end up treating him. And so luckily, I've got some really great collaborators within CMARP, including John Mikulski, Tim Camp, Ravi Balajapalli, and Alexei Gluoff, as well as Wendy Crone in the engineering department. Advance the slide, please. So we all have been working together on a new project to try and create a better model system for iPS cardiomyocytes so that we have a better cardiac model system in a dish, so to speak. These pretty images were taken in Wendy Crone's lab, and what she's been doing is trying to create an iPS cell model that's not necessarily like iPS cells beating around in a dish in a big glob. She's forcing this structure by micropattern geometry so that you get alignment of cells that look a lot more like a cardiac cell, and importantly for this particular case, development of gap junctions that are functional in between cells. Advance the slide. In my lab, I've been working on trying to create a more physiologic action potential, and we have done this by overexpressing KARA2.1, which allows for stabilization of resting membrane potential, which is one of the functions of that protein, and then also the capability of pacing. Advance the slide there. With IK1 enhanced iPS cardiomyocytes, you can then control the pacing, and this becomes really important when you have a set of cells in a dish that you want to do an EP study on, just like we do with patients in the EP lab. Advance again. There we go. So this is an example of some iPS cells beating along in this sort of forced geometry in micropattern geometry from the Wendy Crone lab. So the idea is this. You create a more mature cardiac myocyte, force it into certain geometry, and then you can do arrhythmia modeling on that and potentially add drug to that to then see if that, if what's going to work in the patient rather than trying the drug in the patient and going back the other way. Advance the slide. So, for example, in the beginning I listed 3 mechanisms for ectopic firing. And here, for this particular patient, it may not be this triggered activity from delayed after depolarizations. It may be more of a reentrant type of pattern. Reentry requires both slow conduction around a fixed scar, as I've shown in this big chunk of left ventricle from an autopsy, in which you can see those little schoolboy arrows going through areas of slow conduction around a fixed scar, and that's functional reentry. And we can pattern this then with the iPS cells. And by this cartoon on the bottom, you can see this, again, a squiggly line to forcibly induce slow conduction around a central fixed scar. Advance the slide. There we go. And I hope this projects well. This is brand new data from Wendy Crone's lab. She just sent me last week. So these are iPS cells in this type of forced geometry inside in a dish, so that then, again, the idea is that we would take those cells and then be able to take disease cells from our patient and then control cells, understand the arrhythmia mechanism, and then potentially add drug to that to figure out what's going to work for the patient. Next slide. So in conclusion, inherited arrhythmia syndromes are complex, far from one-size-fits-all, and cookie-cutter approaches rarely effective. Precision medicine or patient-specific treatments are treatment approaches that represent, I think, an important direction for inherited arrhythmia, sudden death prevention. And that our unique UW collaborative effort, I hope that we can create an entirely new iPS cardiomyocyte model system to design effective treatments and provide platform for drug discovery. Next slide. It says acknowledgments at the top. Obviously, this is my acknowledgement slide. I want to just really thank the individuals in my lab, especially Sarah Abazid, who's complete vigilance with the mouse that you've saw that data from, as well as Ravi, Sarah, Matt, and Hannah, who did a lot of the work that you've seen here today, and my collaborators in CMARC lab, as well as Wendy Crone, and my collaborators in the Inherited Arrhythmia Clinic. Thank you very much. I will. Okay. Any questions? Please. Yeah. So the question is, how common is CPVT, and whether or not there should be systematic screening for athletics. The prevalence of CPVT is not really known. It's estimated to be something like 0.1 in 10,000, so it's pretty rare. In Wisconsin, it seems to be more prevalent. We have quite a bit in our inherited arrhythmia clinic, percentage-wise. But the true prevalence of this disease is not very well known. And because this doesn't show up on resting ECG, it only shows up after someone exercises, it's super hard to screen from, and is part of the reason for the very precise questions that primary care physicians are meant to ask student athletes to see if they're really having issues with syncope with exercise. Syncope with exercise is, should pick this up, or, but sometimes people fly under the radar. Luckily, this kid that I presented the first case just got lucky. Any other questions? Okay, thank you.
Good morning, everyone. Doc, is this going to help me? It's a common question that extends across all medical practice, whether you're a rheumatologist or an infectious disease doctor following inflammatory markers, whether you're a cardiologist following troponins after a catheterization, in oncology, if we're following CAT scans when we started a targeted therapy. What we and our patients want to know is the treatment that we're prescribing going to help them? And if it doesn't, why not? Next slide. What we'll be discussing today are new biomarkers that we've been developing to better evaluate our patients' disease as they're receiving the different treatments we prescribe. These are my disclosures for some of the technologies we've developed for these purposes. Next slide. Today's talk is based off of this outline. We'll discuss the clinical context in which we could better explore and evaluate our patients' disease, biomarkers and precision medical approaches in solid tumor oncology, circulating tumor cells and the engineering advances that are enabling more intensive molecular interrogation of these rare cells, and then the translational research that we're doing in my lab. Next. So let me take you into my clinic. This is one of my patients. At the time of this clinical encounter, he's coming in with worsening pain from his disease. He has known metastatic castrate-resistant prostate cancer. He's progressed through 3 lines of therapy, and at the time of this visit, we're discussing what's the next line option that we'd consider. We have 3 different treatments: an immune therapy, enzalutamide, a new hormone-targeted therapy, as well as cabazitaxel, a chemotherapy. Now, this isn't unique to prostate cancer. This is repeated across all disease types, across all stages of disease. Next. So what we're faced with is the common problem in clinical decision-making, that we've reached this disease state transition, and we're trying to evaluate what's the next best approach for our patient. Next. So solution. We go through 3 steps. First, what do we know about the disease? Second, what do we know about our patient? And finally, what do we know about the available treatments that we have that we could offer this patient based on the first 2 factors? Next. So let's come back to prostate cancer. What do we know about prostate cancer? Prostate cancer is a disease that's often driven by the androgen receptor, or AR. The AR is a cytoplasmic protein that when it binds its steroid analog, it translocates from the cytoplasm to the nucleus to activate a transcriptional program that drives prostate cancer. We know that there are many mutations that occur within the within the AR that drive prostate cancer and often drive resistance to the therapies that we're considering. Next. So we know about the disease. What do we know about our patient at the time of this encounter? Well, his original biopsy done 10 years ago had a Gleason 4+5 adenocarcinoma, a high-risk prostate cancer. His PSA is rising, went from 330 to 429. How about CAT scans and bone scans? His radiographic imaging. Next. On his CAT scan, he has a large liver metastasis, as well as retroperitoneal lymph node mets as well. Next. On his bone scan, we see intense radiotracer uptake throughout the spine and pelvis, explaining the symptoms that he's coming in at his clinic visit today. Next slide. So, you know about our patient, you know about our disease. What are the treatments that we have available? The first is Sipuleucel-T immunotherapy, a treatment that's been shown to improve survival for men with metastatic castrate-resistant prostate cancer by about 4 months. Next. It's administered as a single course, costs about $93,000. Next. Enzalutamide, that hormone-targeting drug, oral agent, well-tolerated, average duration of benefit about 8 months, costs about $8,000 per month. Cabazitaxel chemotherapy, about a 40% response rate, improves survival by about 2.5 months and a 4.5-month duration of benefit on average. So, you know as much as I do. What do you want to prescribe for? Next slide. Fundamentally, what we're challenged with is that the information we have about our patients is not sufficient to guide the treatments that we would offer for our patients. Next slide. What we're talking about are biomarkers. So biomarkers are different classes, different types of analyses that we can perform in different clinical contexts that we can use to guide patient care. So the first, we have diagnostic biomarkers. If you've got an oncology consult, I guarantee you've been asked this. We need to know what the tumor is, what type of cancer are we facing. Prognostic biomarkers. I mentioned that Gleason score. Essentially, it's a factor, something that we've identified that says, on general, how will patients do over time? A predictive biomarker. If I'm giving a therapy for a specific target, is that target even present? A pharmacodynamic biomarker. If we're giving a therapy, do we actually modulate the target that we're trying to hit? And discovery biomarkers, meaning if we don't modulate the target, can we better understand why it hasn't worked? Next slide. So what we're focused on in my laboratory are these predictive pharmacodynamic and discovery biomarkers. Can we better evaluate our patient's disease in real time to better guide our therapies? Next. This is precision medical therapy. How has it actually been employed in practice? Well, this was a hallmark study done in lung cancer, and it's actually changed our clinical practice where we do repeat biopsies in patients with lung cancer. Why do we do that? What this study did is they enrolled 37 patients at Mass Gen with metastatic non-small cell lung cancer. A biopsy was done at diagnosis. They then went on to receive a targeted therapy, something targeting EGFR, the drug called erlotinib. When those patients developed progressive disease, they got a repeat biopsy of the lung. What was shocking in those patients, 5 out of those 37 patients, they didn't have that original adenocarcinoma. Now they had a small cell lung cancer, a dramatically different phenotype. Why is that important? Well, the average tumor doubling rate for an adenocarcinoma, about 120 days. Small cell lung cancer, 10 days. Doing this targeted approach, when we interrogate molecular features for these tumor cells, we can better identify patients who will benefit or develop resistance to our treatments. Next slide. And this was really classically identified in this patient here. So this was on one patient on the study who had that original adenocarcinoma identified. They did genotyping that found that this was a tumor that was sensitive to one of these targeted therapies, erlotinib. The patient went on to receive that treatment and had a dramatic improvement in her disease. Next slide. And what you'll see, as that patient had disease response, she ultimately developed progression. Next. And what we found was that small cell lung cancer. The genotyping identified resistance to that EGFR-targeted therapy, and the patient went on to receive chemotherapy and radiation treatment that did control the disease for a period of time. Next slide. However, resistance developed, and what we found on a repeat biopsy was actually that original adenocarcinoma. It was sensitive to the initial therapy that she had received, that erlotinib treatment. Well, unlike standard clinical practice, this patient went on to receive more erlotinib. Had evidence of disease response, but ultimately, next slide, developed resistance. And we found that small cell phenotype reemerged as the dominant clone. Cancer is heterogeneous. There are different histologies that can compete. There are different tumor subclones that could be leading to disease progression or resistance to our therapies. When we better identify those disease clones, we can better treat our patients. Next slide. It's these contexts of use that when we can essentially say, with the different therapies that we have, what biomarkers do we want to develop? Not what we have, what do we want to develop? And when we take that approach, we can visualize, really, there's so many different contexts of use across any disease stage, really across any type of therapy. Next slide. How has this been successfully performed in the last 4 years since that publication came out? Well, 38 new drugs approved in solid tumor oncology. 11 of those had an associated biomarker. There's a theme to this. We're looking at molecular alterations, HER2-neu, BRAF mutations, ALK, BRCA, EGFR. These are all predictive biomarkers, meaning is the target present that we want to modulate. Next slide. So let's come back to our patient. What do you want to biopsy? What do we want to know about our patient? And if we do that biopsy, we might find a molecular feature. But now the next question is, how often should we repeat those biopsies? Do we want to look at that liver met, that lymph node met? How about repeated bone mets? There are significant challenges when we talk about doing these invasive procedures to our patients, though there may be benefit for our patients as well. Next slide. So what I'd like to move into is a different approach to try to acquire tumor cells for these types of molecular interrogation. Next. So circulating tumor cells. It's sort of the concept that when a tumor starts in one place and metastasizes to another, it has to get there through some route. Often it's hematogenous dissemination. Can we capture these rare cells when they're in transit just through a simple blood draw? The challenge is that these are extremely rare cells. We're talking about one tumor cell for every billion peripheral blood cells. Next slide. Here's a study that was done in prostate cancer with a technology developed about 10 years ago, just trying to count the number of tumor cells that could be found in one tube of blood. What they found were that if there were more than 5 tumor cells, patients had a much poorer outcome compared to those who had fewer tumor cells from that blood draw. So counting the number of cells is prognostic for patient benefit, patient outcomes. Next slide. Well, again, not what do we have, but what do we want to know about our patient? So he has prostate cancer, a disease that's driven by the androgen receptor. So what would I like to know? I'd like to know, where is that AR protein? Is it present in those tumor cells? And if it is it in the cytoplasm where it should be benign? Or is it in the nucleus where it could be driving transcription? Well, I'd also like to know, is the AR actually driving transcription? Can we evaluate those gene expression targets that should be induced if that AR protein is active? I'd also like to know if there's any mutations, anything that would predict resistance to the therapies that we're giving. Next slide. So the fundamental challenge, though, is we're trying to do intensive molecular interrogation off of very rare populations of cells, in some cases down to the single cell level. But if we could do those types of evaluations, what we'd be able to move beyond is that counting of tumor cells into, away from the tip of the iceberg into the rest of it. Can we evaluate for therapeutic benefit from the different treatments we have available? Can we look for drug resistance signatures? Can we do genomic analysis? Can we look for gene expression alterations? If we have that information, then we can start to better identify the patients who will benefit from our targeted therapies, but also how we might more rationally combine therapies. Or could we discover new treatments that might further help advance our treatment options for patients with advanced disease? Next slide. So the challenge, though, again, these are exceptionally rare tumor cells. So what we're trying to do is redevelop new technologies that will allow us to do those types of analyses I've described. Next slide. So I had the good fortune of meeting a biomedical engineer here at the University of Wisconsin, Dave Beebe. Dave's group was working on a simplified approach doing microfluidics. When I first met him, I used to think, well, when you're doing microscale engineering, what you're talking about is taking a very complex device and shrinking it down into something smaller. Dave had a very different approach of trying to leverage physics at the microscale. We've all seen a water bug sitting on top of water. How does it do that? Well, at the microscale, surface tension is a dominant force over gravity. So what Dave and his group were doing, next slide, is essentially taking these simplified approaches to redevelop technologies where essentially we can pattern different fluids in physical contact with each other, taking advantage of surface tension, so those different fluids don't mix. Next slide. Let's go to the next one. So here's the first video that I'll show you. Up in this corner here, if you could hit the next slide. What you're seeing here was the initial device that Dave and his group were working on. And what you're seeing in here in yellow is an elution buffer, a wash buffer, and in red is a complex cell mixture with magnetic beads to bind our cell population of interest. What we do is space oil, actually, a different fluid between those different chambers, and we apply an external magnetic force. What you'll see is a bead aggregate form. Those are the beads that have captured our cells of interest. It approaches that interface and is purified from the sample in which it started, goes through a wash buffer, and into an elution buffer. So in about 45 seconds, we've done a complex cell sorting experiment, and our initial sample is still in place for reinterrogation. So now we can capture tumor cells. So what we did, we actually took that initial device and turned it into a vertical orientation, essentially affording us more operational paths, allowing us to take a blood sample from a patient, put it into that input well, and add magnetic beads to capture tumor cells. We can then apply that magnetic force, pull it into the next well, so we can do extracellular staining or intracellular staining for any protein target of interest, such as that AR protein. Can we ask, where is it located in the tumor cell? After we've done that image analysis for those protein targets of interest, well, I also want to look at RNA. I want to know if the AR is driving transcription in that cell. Or I want to look at DNA. I want to know if there's genomic mutations that would predict resistance. Well, taking advantage of those same properties, we have those cells in that well. We can extract both RNA and DNA from that same cell population. If you click the next slide. So here's that video. Here's that chip. There's our beads that have bound our mRNA. We pull it across that magnet. We use a magnetic force to pull it through that oil barrier and into an elution buffer. We then add a high salt lysis buffer along with magnetic beads to bind DNA. Apply that external magnetic force to capture those DNA. Pull it across that oil barrier and into an elution buffer. So a very simplified approach where we can extract both RNA and DNA from the same cell population that preserves those cells for extensive molecular interrogation. Let's go to the next slide. So how have we employed this technology in the lab? Let's go to the next slide. So on this axis, we took a cohort of patients here at the UW Cancer Center who were donating blood. We looked at the amount of AR that was in the nucleus, ranging up to 100% of the AR in the nucleus. What we found in patients before they began any therapy was really significant heterogeneity in the amount of AR in each individual cell. However, when our patients started targeted therapies, abiraterone, ARN, and enzalutamide, these are AR inhibitors, what we found was that the amount of AR in the nucleus dramatically dropped, that heterogeneity almost disappeared. Similarly, actually, with chemotherapy, docetaxel. But it was in those patients who developed resistant disease, when their disease progressed on those AR-targeted therapies. Now, for the first time, we found cells that had 100% of the AR in the nucleus, despite a drug that should be preventing that from occurring. Next slide. Well, are there other predictive biomarkers that we could look at? Well, here was one study that was done in the New England Journal of Medicine, in which circulating tumor cells were captured, and they looked for a variant of the androgen receptor, something called ARV7. They took patients getting treated with enzalutamide and looked at PSA response on this axis here, and found that for the vast majority of those patients who had that ARV7 transcript, they did not have any PSA response, any benefit from enzalutamide. So we wanted to ask the question, could we look in a coordinated fashion for those AR alterations? Can we look for that ARV7 or other resistant variants? Could we also look to see, are those variants actually driving those tumor cells to grow? Next slide. So this was a second cohort of patients here at the University of Wisconsin who again donated blood. These were gentlemen being treated with AR-targeted therapies. We collected blood and looked at their PSA response on this axis here. And what you see that there was a group of men who had rising PSA despite that AR-targeted therapy. We then did CAT scans and bone scans to evaluate the status of that disease. And what we found was that there was a subset of men who had radiographic progression. Their disease was clearly worsening despite the AR-targeted therapies. What we found when we looked for those AR variants were that all of these men had expression of that AR protein. However, a subset of men, almost predominantly those men who had radiographic progression, had multiple of those AR variants. Not just that V7, but also something known as ARV1. We then asked, well, are those variants actually driving transcription? Are they driving those cells to progress? We found that in a subset of those men, in fact, that's true. That on this heat map, what you're looking at here are multiple genes that are dependent on AR activity, and those men who are progressing had significant activity in their AR pathway, suggesting again, the AR is still driving this disease. The drug's not working. We want to evaluate what are some other alternatives, other therapies that might be more appropriate for these gentlemen. Next slide. So here's one of my patients. This was a gentleman who came in. He had presented with metastatic prostate cancer. He received chemohormonal therapy, had an amazing disease response. His PSA went from 35 to 0.7 after 3 cycles of docetaxel chemotherapy and hormone treatment. His lymph nodes almost completely resolved. He felt incredibly better. We actually took a blood draw just when he presented for cycle 4 of chemotherapy and found very few tumor cells and essentially no AR variants and really no activity in his AR pathway. Well, at cycle 5, we checked, he came in for his next cycle of chemotherapy. His PSA actually inched up a bit. That's generally a very poor sign. When we looked at his blood sample, we found a dramatic increase in the number of tumor cells. And when we look at AR nuclear localization versus AR expression, these cells already had developed a phenotype suggesting resistance to the therapy. We looked at the gene expression panel and found, well, now he's got that ARV7 resistant transcript. And now we're starting to see a little bit of activity in his AR pathway. Well, no radiographic changes. He felt fine. So we said, let's go on with this chemotherapy cycle. Let's have you come in for your final cycle, cycle 6. He came in, his PSA was still going up. 1.19, still had a large number of these circulating tumor cells, high AR nuclear localization, but now we're seeing even more activity in his AR-dependent pathway. Next slide. He was tired. 6 cycles of chemotherapy, he wanted to take a break. He said, you know what, you're feeling great otherwise. Let's take a month off and have you come back. Came back in, his PSA went from 1.19 to 41. He had a continued high number of circulating tumor cells, high AR overexpression, but now we're seeing even more activity in that AR pathway, and now a new variant, ARV1, is present. We prepared him to enroll in a clinical trial. He came back in a few weeks later in preparation to start that study, and his PSA had doubled, less than a month, up to 81.4. An incredibly aggressive disease that's still being driven by that AR pathway with multiple AR variants, and again, even higher activity. What this has allowed us to do is, from a blood draw, do these types of longitudinal analysis for pathway activation. Next slide. We want to do a little more information. We mentioned we can get DNA as well from these cells. This was one of my patients with a 70-year-old gentleman with metastatic prostate cancer, extensive liver metastases, extensive bone metastases as well throughout the ribs and thoracolumbar spine. Next slide. We looked at his circulating tumor cells after he progressed on enzalutamide, found multiple variants, multiple alterations in his AR pathway, as well as AQ gain and an amplification of the androgen receptor itself at the genomic level, suggesting it's not just those AR variants, there's also overexpression that's driving his disease. Still AR dependent, but resistant to any of the therapies that we currently have. Next slide. That contrasts with this gentleman who, as he's progressing on enzalutamide with large retroperitoneal lymphadenopathy as well as bone metastases. Next slide. We similarly find AR-dependent pathway activation, incredible phenotypic heterogeneity in the amount of AR expressed in his tumor cells, as well as the amount localized to the nucleus, but only AQ gain, no AR amplifications. So when we start to do these longitudinal analyses, we can find interesting, fascinating molecular information about these patients' diseases. Next slide. Now the AR itself, what I'd like to discuss in the last few minutes are some of the clinical trials that we're now doing in my laboratory. So we've taken the same AR pathway analysis. We've now employed it in 4 multi-site phase 2 clinical trials in which my lab is the central processing site. We also have an upcoming phase 2 clinical trial that's actually being run through the Big Ten Cancer Research Consortium. I actually found out that this was accepted when Ruth O'Regan gave her Grand Rounds talk a few weeks ago. It's been approved in which patients with triple-negative breast cancer also can express the androgen receptor. So we're actually going to do the identical analysis that I just showed you for patients with breast cancer in this multi-site clinical trial as well, trying to evaluate the benefit from two treatments, bicalutamide and ribociclib, a CDK inhibitor. Next slide. We've employed the same type of technology in other disease settings. We've done this in prostate cancer, breast cancer. What about pancreas cancer, an incredibly lethal disease? I don't know if any of my GI oncology colleagues are here today, but they've graciously consented their patients, and we've been collecting blood samples and found significant heterogeneity. This is a very different disease. We already knew that from some of our other cancers, such as breast or prostate cancer. One of the things we found was significant heterogeneity, meaning that we can identify tumor cells in circulation. However, they don't express the classical markers that we expect from other diseases, such as EpCAM. But when we look at other markers, such as Vimentin or NK adherent, we start to see some cells that have those phenotypic signatures. We'll show you some new data that we just got last week. Next. When we do gene expression profiling of those circulating tumor cells, we now identify for the first time gene expression alterations. So from a blood draw, identifying pathways that may be active in patients with metastatic pancreas cancer. Next slide. How about lung cancer? Actually, lung cancer is somewhat similar to pancreas cancer. Acts in a very different fashion, meaning that the phenotypic heterogeneity is really quite profound. We started exploring new markers in lung cancer, such as a protein called MUC1, and found in these 7 patients with metastatic non-small cell lung cancer that we can identify circulating tumor cells based on this MUC1 marker. Very high numbers, up to 50 tumor cells in that one patient. Next slide. When we do gene expression analysis, we can actually identify markers that suggest resistance or benefit from different targeted therapies. There are new targeted therapies targeting FGFR1. Some of our new treatments that target immune therapies. We can identify PD-L1 expression in the majority of these patients. How about BRCA1 alterations? It would predict resistance or benefit from chemotherapies. So it's these types of molecular analysis, when we employ them in different clinical contexts, that we can identify potentially relevant, clinically relevant and actionable targets. Next slide. This is a project in breast cancer with Mark Burkhardt and Beth Weaver, looking at sensitivity to paclitaxel chemotherapy. They've previously identified that when you give more paclitaxel, that if you see what's called chromosomal instability, that these are cells that may be more or less resistant to this taxane chemotherapy. So, from one of Mark's patients, we collected blood and we looked for circulating tumor cells, and similarly identified what's known as centrosome amplification in these circulating tumor cells, again, potentially as a predictive biomarker of taxane-based chemotherapies. Next slide. Well, let's come back to our patient. Let's finish off there. He got enzalutamide. It was a toxicity-based decision. He wasn't feeling that well. We didn't think chemotherapy would be well tolerated, so we went with enzalutamide. He had no benefit. He progressed within 2 months of therapy, went on to hospice, and died shortly thereafter. He had donated blood for circulating tumor cell analysis. We didn't have this data at the time when we were making that clinical decision, but we found that despite his AR-targeted therapies, he had cells that had 100% of the AR in the nucleus. He wasn't going to benefit from further AR-targeted therapies. That's what happened clinically. This is the type of setting where we might have considered other treatments if we had had greater molecular information about our patient's disease. Next slide. What we're doing now is developing the context in which we can apply these types of biomarkers. So these are some clinical trial concepts, essentially asking for patients when they started targeted therapy, we can collect blood at baseline. When they have their first radiographic imaging at 3 months, we can collect another sample, and then we can look for signs of either intrinsic resistance, the early development and resistance of disease, and these acquired mechanisms of resistance to our targeted therapies. It's a fertile area for research. We can apply this really across any context of use, any disease, any stage, with any targeted therapies. And these are some of the projects that are going on now, and we have other opportunities for other trainees who would like to do this type of research. Next slide. Next slide. So with that, I'd just like to thank you for your time and your attention. And most importantly, I want to thank our patients and their families. We've had over 300 patients sign consent and donate blood for these types of studies. We can't do this in mouse models. We can't do this with cells in a dish. We have to have patient samples, and it's really an honor to be able to work with these people. Thank you for your time and attention.
We have time for one or two questions.
Josh, in the first great presentation, in the first longitudinal patient with the 0.9 PSA, it seemed that the distribution on the scatter plots changed from quadrants. Could you comment on that at all, and is that meaningful?
It's absolutely meaningful. There's this phenomenal phenotypic heterogeneity because it's not just is there a transcript present. What I want to know is what is the protein doing. So we saw that shift from not just nuclear localization but to AR overexpression as we saw that shift in those cells, suggesting again that there's so much more AR being produced as this disease is progressing. So AR-targeted therapies may not be the best approach for this gentleman.